had a couple patients here that I thought were really awesome to look at from the perspective that both of them were totally different. Both of them had totally different issues that they came in with, but yet both of them had the same problems when it came to how to find the floor. And one was a professional athlete that had very limited ability to push off because his glutes wouldn't kick in, and his ability to push forward was difficult because his anterior hip capsules were sacrificed, and he didn't have a lot of ability to internally rotate his two femurs and his acetabulum. But the acetabulums were probably right where they should be. He just has a shallow pelvis and a shallow socket, and I think they even told him he had hip dysplasia. Is that the same patient?
No,
or was that a different patient?
that's the one.
But anyway, he was really, really shallow, and he couldn't get enough AFIR. And when he got into AFIR, he liked it, he loved it. He swang and he swayed, and he said, "Man, this is the cat's meow." But he didn't know how to get there. Then we had another patient that came in, and she's probably been doing kickboxing and lifting, weightlifting, and glute development since she was probably 2 days out of the womb. She has a rear that looks like it. She has a very narrow waist, very deep lordotic back, good sets of glutes, over glutized, and both of them walk the same way. And the reason they both walk the same way is because they don't have the sense or the urgency to correctly utilize the floor at the correct times of the gait cycle. And so when we see them doing things, we see similarities, but I'm not sure we were all ready for that until I saw both of those patients and realized we put glasses on one individual just to soften the space around that individual so that he could actually see something other than a net and a basketball or the floor that he has to look at or whatever it might be. He has a long-standing history of ankle issues. I wouldn't go over all that. And there's reasons for him doing what he does as a 7-foot guy. I mean, he's pretty daggone tall. And then the other lady, she's on the floor, she's kickboxing, she's lifting, and she can't sense the floor. And her problem isn't so much that her two eyes don't have the ability to give the brain the message the brain wants. Her brain is saying, I see everything around me, but I just don't appreciate what I'm seeing around me because I don't know how to utilize that stuff around me, even though I see it correctly. So we actually had to put a lot of lens across her eyes to trick her. Probably the most significant amount of trickery that went on in this clinic since I started working with Dr. Wise years ago. In fact, before I met Heidi, I would send these kind of patients over to her and say, "Heidi, please put this degree of lens on this patient so we can break this break this back." And she did for me, and she was nice enough to do that. But I know it discolored her a little bit because it's like, whoa. Why are you doing that? I normally do that with brain injury patients, or you said yesterday, stroke patients. Well, the reason that both of them are unique is that both of them have the inability to find the floor for one reason, and that is because they do not know how to unlock their knees. And I think we walk around the clinic and we forget about the knees. So you don't hear me talk about quads, Eric, in courses, but we talk quads all week this week. It's a two-joint muscle. When the knees don't bend, you kick balls. When you don't bend the knee, you don't have a two-joint muscle anymore. If you lock out your knee, you're walking down the heel. Because if you lock out your knee, you can't get your heel up. You're an extension. So I thought I'd bring in the gait chart in and show you what both of them have in common and what we had to do with both of them. Jason, I told you on one of them, I don't care what we do with them, let's get those knees to go forward. And let's do so with his heel down. And then let's make sure he's going to do fine when he walks in that court and dribbles. But when he's working out, he doesn't know how to unlock his knees. And are you working with the other one, Torn?
Yep.
The other one has a real big problem. She's walking around like a weightlifter. She's carrying weight. Her hands are behind her, and she has no weight in her hands. She's a petite little gal above the waist. She just doesn't look right. She's got from the bottom, from her hip down, she's built, and from the hip up, she looks like she hasn't been working out at all. So she's imbalanced and she's got all this power, but she can't harness it. There's so much power she locks out. Both of them are walking on declines, not inclines. Both of them walking on a decline. I'm going to show you a graph, and I want you to write this down. Knees need to bend. Knees need to bend at the end of heel off. So when you're going off to your heels, at the very end of that heel off stage, your knee has to bend. You're getting ready. I'll show you this graph in this on this graph here in a minute to take a load. You are taking a load. Now, if the knees don't bend and you walk, you're going to leave the floor quickly. The toe is going to do all the work. One had beautiful feet. There's nothing wrong with her feet. They're gorgeous. But she doesn't want her socks and her shoes on her feet in the morning because she can't sense the floor. These people tell you what's going on. I get up in the morning and I want my socks off, shoes off. I want to walk around nothing on. I even tried minimalist, she said. Doesn't help, but I tried it. She can't sense it. And I didn't have the heart to tell her, you can't sense it because you don't know how to unlock your knee, because it would be difficult for her to understand that. I told her she can't get grounded. She can't feel the ground. And then the next question, the obvious question was why? She's been in our vision clinic a number of times torn, and you've done a great job with her, and she's neutral. She comes in. Now, why can't she still not find that floor? She had a problem. She had a problem when she gets up and she starts moving. She prematurely leaves the floor with her heel because she doesn't know how to end, if you will, a cycle, one cycle, that gait cycle, one phase of that gait cycle, which I'll go over with you in a minute. The other gentleman has a problem with push-off. At the end of push-off, his knees should bend. His doesn't. He's running down the court. You know how he bends his knees? He turns his feet out. So Paul would call that pronation. He's a pronator. But he really is turning his feet out because he has anterior hip capsules that told me that. He spent them. He's been doing it all his life. Now, neither one of them are correctly bending their knees at two phases of the gait cycle, but they both have the same problem. They can't find their quad. They can't find their quad for support, for lift, for push, for power. Last week we talked about kinetic energy. They don't have it because they can't bend the knee. So they're both using hip flexors. One's using hip flexors for one reason differently than the other one. Hip flexors pull pelvises forward. One lady, her pelvis is forward and her back is deep. On the other one, his back is kind of in the right position. He's really not abnormally positioned with his pelvis. But what he's doing is he's taking his psoas and he's using it as a glute. He's taking his femur and rotating it out, torn. And his biggest glute he's got is his hip flexor, called the rectus and the psoas, which is two muscles working together in that AIC chain. And he's taking that muscle group and he's rotating those legs out so he can clear the other side at the expense of the side he's on by locking out his knees. So he can't go heel-toe, and I'm using Dr. Coffin's terminology. He can't go heel-toe. The only way he can walk is he has to waddle. He has his base of gait wide. He can't bring his knees in. And as you noticed when you were working with him yesterday with those glasses on, he doesn't even know how to get his legs out now. They have to come in. He has no problem getting them in as long as he saw that space around him that gave him the ability to let go of his kneecap. So we're back to patellofemoral pain. We're back to those discussions. Well, you need hamstrings for that. They both need hamstrings. The difficulty is they both have them. We can stop her at 90 or we can go above 90. We can stop him at 30 or we can go to 90. It just depends on the position he's in when it comes to the ability to unlock his what? Knees. And last comment. If you unlock the knee and you squat and you lock the knee, the floor is going to go up. The toes are going to go up. That's called dorsiflexion. So let's just kind of keep that in mind. A knee that bends is an incline. A knee that doesn't bend is a decline. So I gave you a sheet of 20 things to work on. Remember I said to keep grounded? Let's put one more on there, 21. Keep the knee what? Bending at the right stages of gait cycle. And if you keep the knees bending, because that's what we do for a living in Prime, and we keep the heel down, then we got the calcaneus. And we're right back where we should. So we're not really probably looking at knees enough. Does a really good job of telling us that. She can control herself in her tone, you know, with knees that have to flex. As soon as she flexes her knee, because you have a patient that literally cannot flex her knee. She doesn't know how to. She has no quads. But she's doing a better job at flexing her knee than these two people we're talking about right now. Because if she doesn't take the risk of risking the fall by locking her knee, she can't dance. She can't create. She took a risk. We gotta get people to take those risks a little bit more. They gotta bend those knees. So I'm gonna show you a picture. So if you look at the gait cycle, and you see the gait cycle, the progression, forward progression, right here, about 15% of that gait cycle, you start to hit a toe. And when you start to bring that heel off that ground, that knee's got to start to bend. Okay? So at the end of heel strike phase, so I heel strike, I start to go to my toe. If that floor is not coming up, you're pushing the floor down and your knee will stay what? Straight. So I don't need 3 steps, Heidi. I can tell what you're doing with the lens with 3 steps. Because if they take 3 steps and their knee doesn't unlock at the end of heel strike phase of gait, where they've got to now go through what we call glide. They're transitioning forward at that point. That's called mid-stance phase of gait. That mid-stance phase of gait, what do they have to have with their feet? Pronation. So if you can't bend your knee at pronation, you're going to pronate more by externally rotating your legs. Now, we don't talk about that in the advanced integration course because we just forget, I think. We go heel toe, but you know, Paul's working on the hip. We're all hip what, Jason? You wrote the best. Wait till you see this man's part 2. It's awesome. It is perfectly written. But there's really no discussion about torque across the knee if everything's going correctly. You shouldn't have a lot of torque across the knee. What's going to put torque across the knee? If you can't keep that knee bent right there, get it bent right there, and where did I say the second one was? At the end of what phase of gait? Push off phase of gait. So here we go. We're going all the way over here. Right here, that knee's got to be what? So you can then do what?
Extend it.
If you can't get that, and you can't get that during that process, if that knee doesn't stay flexed during that process, don't let this concern you, that knee is still flexed. If that knee isn't flexed, those quads are off. Those quads are off as forward pushers. Those hamstrings are off as forward pushers. Now you got to use your calf and your hip flexors for forward progression. And the floor is going to go down. Now you know why I'd regret this. Does that make sense, everybody? So, in order for your floor to go up and stay neutral when you walk with horizontal plane activity called the floor, your knee has got to learn how to take a risk at the end of weight acceptance and at the end of, when you're starting to pick up, at the end of push off. You got to start to bend that knee again. Each one of those individuals has a problem. The first individual has a problem, or the lady has an individual with that. She's walking, locking out. She's got the strongest quad you can think about. Her hamstrings are strong, and she's nurtured her butt to lift. She's lifting, and this is occurring here. Does that make sense? Mm-hmm. She can't unlock that knee. And that's pathomechanics of gait. Her knee and her ankle are doing the exact opposite things they should be doing in mid-stance. Now, she doesn't know that because she's got beautiful feet. And the reason why she can get away with it is because she's got the strength above to do it, to control it. She doesn't have to roll her fingers out. She's heel toe all the way. But between the 2 players, or the 2 people we had this week, Jason, I would much rather have the person you're working with, the 7-foot guy that's got all the messes with his feet, to work with, because he's going to get it so quickly. He wants it, he knows it, he felt it, he has it. Guess what, Torn? Your lady is still struggling. What am I really feeling? So I asked Dr. Weiss, let's lens her up. My direct statement was, let's ask her to go out and kill herself.
She loved it.
Let's go out and ask her to kill herself. Let's go ask her to do everything in the world she wants to do, provided she has those legs on. So she can learn how to fall and take risks, because she doesn't know how to risk. She's not a risk taker. She's a weightlifter. She's already no kinetic energy, no potential energy. She's got her hands and she's jacking. What do I tell her she does every day out there in the western part of the state?
Jackhammering her spine.
She's pounding posts in the ground every day. That one is going to be a problem, because sooner or later L5 is going to give, and how it didn't give is beyond me. L4 and L5. Is that helpful, everybody? So this knee bend is going to allow that floor to come up, and this knee bend is going to allow that floor to come up. If in this process those knees don't somehow bend in that forward progression state of 15 to 70% of the gait cycle from mid-stance push-off to early pick-off, if you can't keep that knee bent on the one you're standing on, the ability to swing the other leg without overextending the system with dopamine and adrenergic activity goes what? Well, now you've just taken this whole system and you just cranked it up. Did I go over that too fast? Did that make sense?